Good morning. It is promptly 8 o'clock, so we're going to get started. I want to start with a land acknowledgement before we get on to a series of excellent presentations this morning that will represent a culmination of a lot of postdoctoral work. So we're very excited. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of the free and slave labor of Black people. We honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of the privilege and oppression and how they play a role in the lives of patients, families, and employees as we strive to be anti-racist and improve care for those with less privilege. So we will turn it over to our first presenter this morning. China Bolden will kick us off.
Good morning, everyone. I am Dr. China Bolden Jarvis, and I am here to talk with you about some work that I've been doing with folks here and across Washington State on expanding the mental health workforce for youth and families. I first want to acknowledge that this work was funded by a CDC grant and support team that have been supported through that funding. And this work was done in collaboration with folks from our department, Dr. Wissau, Trevino, and Hemke. And then the FAST team, I've been working with the FAST team for a number of years, and our work really influenced this. As we have witnessed and as we all know that in recent years, the COVID-19 pandemic has brought alarming increases in mental health symptoms. And the good news is that most recent data indicates that there's been improvements. And despite these improvements, there's still alarming rates of poor mental health in youth. And these are just some of the current statistics that we still see. And one of the major challenges in continuing this positive trend that we see towards reducing these numbers is the limitation of the workforce and the capacity of the healthcare workforce. And in Washington State, on average, we have about one mental health provider per 360 people. And not surprisingly, that number dramatically changes depending on where you are located. A promising approach to addressing similar problems is the use of paraprofessionals in healthcare settings. And paraprofessionals within healthcare have had many different names. Folks within our department here have done work with paraprofessionals, Dr. Trevino's work with promotoras, and Dr. Hemke's work with peer partners. And recently we have, in Washington State, acquired community health workers. And one of the things that all of these paraprofessionals have in common is that they support and deliver various different healthcare needs within the community. And several studies have found benefits to having paraprofessionals support and deliver mental health interventions specifically. There are several meta-analyses that in this area that have found things like there's no difference in outcomes when a paraprofessional versus a licensed clinical provider provides an intervention or service. And further findings from Furr and colleagues indicate that there's no evidence that that patients are negatively impacted by peer intervention, and that they are positively impacted by an increase in hope and an increase in quality of life when interventions are delivered by paraprofessionals. Community health workers have been embedded here in Washington in many clinical settings. There's been an effort in recent years to increase the healthcare workforce across the state, and this was largely born out of the COVID-19 pandemic, and the impact has been promising from having community health workers within our settings. In 2022, the Healthcare Authority, along with other groups, worked to secure funding from the CDC to embed community health workers in primary care clinics across the state. And this has allowed for community health workers to be positioned at both OBCC and South Clinic that are a part of our community. And the overall goal of having community health workers in those clinics was to utilize community members to support families as they awaited services. And this brings me to some of the things that have been on my mind in recent years. So a lot of this project is ongoing, and we're in the beginning stages of this work. But initially, I was very curious to find out why here in the U.S. we don't leverage the results that we see using lay individuals that we see in low and middle income countries. Of course, there are many reasons, and we're starting to see that more and more the healthcare sector is beginning to move in that direction and utilizing paraprofessionals. And given what we know about the impact of paraprofessionals on communities, I've been curious to see if community health workers specifically can increase access to evidence-based mental health services, can increase the problem that not increase the problem, but increase diversity within healthcare settings, which we know is a big problem across the U.S., increase community engagement, community knowledge about mental health concerns, and buy-in to do something about these mental health presentations, and reduce stigma that's associated with mental health symptoms. So, this brings me to this specific project. I was lucky to be sort of brought in to the work that Dr. Wasau and Dr. Trevino were doing. I had specific aims that were funded through the CDC grant to sort of understand using this iterative process of adapting an evidence-based mental health intervention. Like, can we adapt that and train community health workers to meet some of the gap that we have? I was also, and continue to be interested in understanding following training, the impact that community health workers have on the healthcare system in general. You know, things like reducing wait lists, increasing access to folks who otherwise would say no or not follow through. And so we engaged in a process of training. We initially wanted to, so the community health workers across Washington State have received several trainings. We wanted to review those trainings, not duplicate efforts, but leverage the trainings that were being done and the previous knowledge that community health workers have, and this aim towards seeing if we can have more impact through delivering support and interventions. And so we introduced a foundational sort of low-risk training for challenging behaviors. The previous slide that I had showed indicated that within youth, we do see that 1 in 11 kids on average has some sort of challenging behavior that greatly impacts their functioning. And we know that disruptive behavior leads to poor outcomes for a large number of individuals. So that number, exacerbates over time if gone untreated. And so parent behavior management training was like an ideal intervention to sort of start with. And so we did basic training and sort of foundational skills associated with parent behavior management training. We did trainings related to confidentiality and mandating reporting, talked about the structure of treatment in general, discussed things like multiple relationships and boundaries and self-disclosure. We engaged in quite a bit of training related to motivational interviewing and other forms of communication that can be therapeutic. We talked about common barriers to parent behavior management training and engagement within that intervention. And specifically, the community health workers were trained in the FAST-B skills that included helping caregivers understand challenging behavior, special time, giving effective instructions, intermittent reinforcement and positive attention, planned ignoring, timeout, and privilege removal, all of which are considered to be sort of core foundational skills to addressing challenging behavior. And we then evaluated community health workers' comfort, competence, and confidence in being able to support families who are engaging in this intervention. And the goal is to take these findings and to reiterate this process based on results and feedback. So when some other things to note about our training, our team was multidisciplinary, so we had 2 psychologists and a psychiatrist sort of engaged in this work. Community health workers did approximately 6 hours of asynchronous learning and then 12 hours of live training. There was lots of opportunity for role play and then follow-up consultation and supervision. So we assessed pre-training and post-training, going back again to comfort and confidence and competence in being able to support families in this way. And we found pre-training that the community health workers on the whole had no previous parent behavior management training. And then you'll see that these are just a few findings listed here. That community health workers, we saw a 30% increase in their comfort being able to engage in parent behavior management training. We saw a 20% increase in their comfort and confidence in being able to engage in motivational interviewing and supporting families to feel encouraged that they can do this and address challenging behaviors. And then we saw a 15% increase in comfort related to troubleshooting engagement barriers. So there's still a lot of work to be done, but it's been exciting and promising to see that we can take things that, for folks like me and you all, take many years of training to do. We can figure out what is really impactful for communities to mitigate some of the challenges that we see and uplift communities to be able to engage with one another. And one of the things that is really important that I want to note is that we had a very diverse group of community health workers. So going back to bullet point number 2 here, 80% of them reported some part of their identity as being belonging to a marginalized group. Majority of them were bilingual and provided services in languages other than English. And we know that those are things that are limitations within healthcare settings that increase barriers for communities to be able to do better and feel better and have better overall well-being. So we have a few collaborations in the works that to move this work forward. The Washington chapter in Child and Adolescent Psychiatry, along with the FAST team, have been collaborating on providing trainings to all of the community health workers across Washington state. So that work is happening. And understanding what the limitations are to a community health worker role. So really trying to figure out what is appropriate, what can be done, and maybe stretch those limits just a little bit so that we can see continued growth and impact, a positive impact, and ultimately having a positive impact on outcomes. We are also in collaboration working on adaptation of the FAST parenting, so looking at this work related to older youth, which we're not specifically addressing suicidality and interpersonal peer problems and substance use, but we know that those are really prevalent among that age group. And so can we see similar results of empowering parents to then be able to have a positive downstream impact on teens who are experiencing these things? And then, of course, there's the aim of further engaging communities. Personally, I'm seeking training grants to be able to continue this work, and then considering what does increasing access look like, so school-based health and being able to support school-based health more. All right, thank you all. And I would like to introduce you to Dr. Catherine Dick, who's going to be presenting next.
Hello, everyone. Good morning. I'm excited to be here today. I'm Catherine Dick. I'm a postdoctoral fellow at the Autism Center. I work across a variety of clinical services and a few research projects. So today I'll be talking about one of the research projects I've been involved with over the past year, which is a trial of Ruby in educational settings, or Rubies. And specifically, I'll be talking about my involvement in a qualitative coding process that our team has used to better understand paraeducators' experiences using this intervention. Okay. First, I'll give an introduction to Ruby, though many of you are likely familiar. Ruby is a parent-mediated intervention for autistic youth who have co-occurring challenging behavior. It has a robust evidence base and is geared toward parents of preschool to school-age children with moderately impactful challenging behaviors. So think meltdowns, aggressive behaviors or mild self-injury, transition difficulties, or other behaviors that are getting in the way of kids functioning at home or in the community. Ruby's focus is on teaching parents to understand behavior, especially through the lens of autism, to understand the function or purpose of a behavior for the child, and then apply function-based strategies that they learn across 11 core Ruby sessions to decrease behaviors that are getting in the way and increase adaptive functioning. Okay. Ruby's widely used as a parent-mediated intervention, though, as we all know, so much of children's time is spent in the school setting, which means that schools actually end up being the primary intervention setting for autistic youth. At least 50% of youth on the autism spectrum have co-occurring behavior challenges, which can understandably impact learning in the school setting, as well as social engagement. And behavior management also contributes to school staff's burnout and turnover. So this all motivated a recent and ongoing redesign of Ruby for use in educational settings, or which is called Rubies. The redesign involved modifying Ruby content for acceptability, feasibility, and appropriateness for schools, and importantly also focused on who the target end user of Rubies would be, or who in schools would be targeted instead of parents to learn and deliver the intervention. Through this redesign process, paraeducators were identified as the best fit and target end user of Rubies. They spend extensive time with students and have access to the student across both general education and special education classrooms, and they often have minimal formal training in autism-specific behavioral interventions. So over the past year, I've been lucky to be a part of the research team on the SPACE study, which is the first trial to evaluate the effectiveness of Rubies. And Jill Locke and Karen Bears are the PIs of the study at the UW Smart Center and at Seattle Children's. And in this trial, 68 paraeducator student dyads were enrolled nationally. I think it's so exciting that paraeducators were enrolled across 12 states. Nothing was required of students or families to participate other than consenting and completing questionnaires across a few time points. And then paraeducators who were enrolled were randomized to either receive Rubies or to a psychoeducation-only control condition. So 34 paraeducators received Rubies coaching virtually. My involvement on the project has primarily been as a Rubies coach, and then I, along with a few other members of our research team, have been carrying out a qualitative coding process of paraeducator interviews for those who delivered Rubies to learn from their experience using the intervention. The aim of these interviews was to better understand paraeducators' use of Rubies with the goal of continuing to fine-tune this redesign and to support Rubies implementation in schools. To do this, we've used a process of qualitative coding called RAP coding, or Rapid Analysis Procedure. Much of the information publicized about this method comes from Alison Hamilton, and specifically from the sort and sift, think and shift method for utilizing qualitative data. The rationale for this type of rapid approach is that many qualitative methods are often time intensive, but often there's a time sensitive need to understand findings, for instance, using results to modify implementation at a next phase. And this was really the intent of collecting these data for our team. The RAP coding approach is telescoped, so there are a few stages of coding that ultimately lead to synthesized themes for your areas of interest. It's highly flexible, so it can be tailored to your team's specific needs. It's not a fit for all types of qualitative data, and it's best suited for semi-structured data, like a semi-structured interview, where you have 1 or 2 questions that correspond to one domain or area of interest. Okay, so to expand a bit more about this process, first, using RAP coding, you identify your domains of interest, which usually correspond to a small set of questions. And your team, this is part of the flexible nature of this coding method. You create a summary template specific to your data that you use to code each transcript. You distill your responses into quotes, make notes, and identify themes for each question or topic. And once your team test drives this template to establish consistency between coders, you divide and conquer to work through your data. And then finally, this culminates in creating 2 matrices. I'll show examples of these on the next couple of slides. The first matrix lists themes that arose for each domain at the respondent or participant level. And then next, as a team, you create a summary matrix where you compile main themes that arose for each domain overall. So here's an example of what the first matrix might look like, with domains and corresponding questions in each row, and then themes that arose at the respondent level in each column. And then next, your team works from that first matrix to create a summary matrix where you compile several main themes that arose for each domain. Our team is currently at this stage of the coding process. So next, I'll share more about what domains we were interested in, what was assessed in these interviews, and I'll share some quotes from the interviews as some interesting anecdotes. Okay, so broadly, these paraeducator interviews assessed Ruby's implementation, including what worked well, and how Ruby's may have benefited the student, the paraeducator themselves, or any classroom benefits. It assessed challenges implementing Ruby's, as well as what supports would make delivering Ruby's easier, or what would help paraeducators' continued use of Ruby's. It also assessed use of a visual kit that was provided as a support for the paraeducator to use. Next, the team was also interested in generalization of Ruby's potentially across other students and other school staff, so how paraeducators might have shared with the rest of the school team, in addition to some summary questions for broad insight into how to make Ruby's more useful in schools or other relevant feedback they wanted to provide. Here I'll share some example quotes for a few domains. So the first paraeducator shared about what worked well and said most of it went well. I didn't always get tracking done, but the coach would type everything that we talked about and sent me everything. So I had a completed workbook. Another paraeducator shared about challenges, saying a lot of challenges are definitely classroom-based, including the student not being in school or us not having enough prep time or enough staff. Another shared about benefits as a paraeducator, saying it helped me be more patient and see things from a different perspective. So this action here is calling for something over here they just don't know how to ask for. It helped me identify different aspects of the behaviors I was seeing from the student. In the area of generalization, one paraeducator shared about use of Ruby's with other students, saying we used things like a timer for other students, and at certain times of day, like lunch and recess time, we used visual cards we would show them, and a picture of a timer we wait, like it's waiting time. They shared, another paraeducator described sharing with their team, saying we have weekly check-in meetings when people are covering me for a break, or if I was out, giving them information about what works better and how did I put it into play in a way that would be most effective for the student. And finally, here are some quotes paraeducators shared about making Ruby's more useful in schools. One said, it would be an amazing program for all paras to undergo this training. Being able to recognize certain behaviors and treat these behaviors for all of our students would be awesome. We'd have less conflict if all of our paraeducators had more training. Another shared, it'd be great to have all paraeducators, especially the first month of school. You're just getting to know your student, building a relationship, understanding what triggers might be, and then walking through Ruby's 1 week at a time. Okay, so to summarize, our coding process is nearly done. We'll be finalizing this very soon, and then you're likely wondering about where Ruby's goes from here. My role on the project is winding down, but Jill Lock and Karen Bears and the team are continuing to test Ruby's implementation. including this coming school year, to use and are using feedback from several sources, including some from these interviews. So the next phase will incorporate these results, and we'll be comparing Ruby's alone to Ruby's plus a few newly developed implementation strategies. So for example, a pre-Ruby's implementation session with school staff about what people have found to work best, new school-specific video examples, among other strategies. So lots of exciting work for Ruby's on the horizon. And thanks for listening and letting me share about this today. And next up, we have Dr. Andrew Gepti.
So today I'll be presenting on one of the research projects I've been working on during my postdoctoral training. So looking at the role of negative life events, perceived social support, and alcohol use in association with suicidal ideation across the lifespan. And big shout out to my mentors and collaborators on this project. As you may know, suicidality among our youth is a major mental health crisis. It is now the third leading cause of death among youth, just behind accidents and homicides. And over time, we've been seeing increases in ideation, suicidal attempts, and completed suicides. Now, when thinking about different risks and predictors of suicide, suicidal ideation is one of the possible predictors for suicide attempts, even though not all suicidal ideation transitions to attempts. And so with that in mind, it's important to identify risk factors that might lead to suicidal ideation among youth to inform interventions. So in thinking about risk for suicidal ideation, a major contributor is the response to stress. And generally, there are two possible frameworks in looking at how stress can influence suicidal ideation. One is a stress exposure type of framework. Basically, someone experienced some sort of stressor leads to suicidality. And another framework is a stress generation type of model in which there's some sort of predisposition, whether it be some behavior, something genetic, that leads to the experience of more stress, which then leads to the outcome, suicidality. So in thinking about different risk factors for that could contribute to the stress response, one behavior that's been associated with suicidal ideation is alcohol use, especially starting in adolescence. Pretty consistently, negative life events is associated with suicidal ideation. And when thinking about risk factors, you also want to think about protective factors. And social support, with no surprise, is protective against suicidal ideation. What's missing is just understanding how these risk and protective factors interplay with each other, especially looking at this across a lifespan, starting in adolescence and then progressing later in adulthood. So seeing the developmental progress. So with the current study, my goal was to identify is there a developmental progression of suicidal ideation starting in early adolescence and going on through to adulthood. Hypothesized that alcohol use and negative life events should be associated with increases in suicidal ideation as per the literature, and that social support will be protective. So the data I used was from the Developmental Pathways Project. It's a longitudinal study starting at age 12 back in 2006 and continued across 9 waves up until age 28. I had 137 participants, majority female and persons of color. And for the study here, I focused on 4 time points, time points 6 through 9. So 6 is middle adolescence, so 15-year-olds. 7 is 18. 8 is 22, so after college-ish. And then adulthood at time 9. And to look at the different risk factors, for alcohol, I looked at frequency of alcohol use in the past. Negative life events was assessed through a count of how many they reported. There's a perceived social support measure from different domains of different social supports. And then the suicide ideation is the occurrence in that wave. So with the structured data being as it is, I ran a path analysis of a cross-lag panel model, basically with the 4 waves of repeated measures, allowing them to be regressed upon themselves. So I use a Levon package, if anyone uses R. There's a lot of missingness, especially in one of the waves, and so that was handled through multiple imputation. And then to assess any sniffing pathways or indirect effects, use Monte Carlo confidence intervals. In terms of training, this is probably the most difficult part, was figuring out how to do everything in R, as my past training has been in other statistical packages. So this was a fun learning process. All right, so the results. So let's start off with just across waves for each of the factors. So for alcohol use, we see the associations start at wave 7. So again, this is at age 18. And over time, it's positively associated. Life events, early life events begets more negative life events. Social support also consistent, starting again early adolescence. You'll notice that we're missing wave 4 for social support. I'll get to that. That was since wave 9 was added to the study. They did not include a social support measure at that wave. So that's a limitation. And interestingly enough, there wasn't any association between suicidal ideation over time. So now looking at the cross effects. So for alcohol use in age 18 predicted negative life events at age 22. Negative life events at age 22 predicted ideation at age 28. Now, in terms of social support being protective, we find that social support in age 18, so late adolescence, associated with less negative life events around at emerging adulthood, and social support itself in emerging adulthood associated with less suicide ideation in adulthood, depending on how you want to specify those age groups. So now let's look at the possible pathways that we see. So first, this possible mediation going from alcohol use at age 18 to more life events in age 22 to more suicide ideation in age 28. So looking at the confidence interval, so we want to see there's no 0 in between the confidence interval, so we have significant indirect effect and a sizable effect size. So then we saw life events, so over time. Life events starting all the way in middle adolescence to ideation in adulthood. Also find indirect effect, smaller effect. Now we have the protective path. So social support in age 18 to life events 22 to ideation. And yeah, so there is a protective effect that basically social support back in late adolescence associated with less ideation in adulthood. And then social support as well, we find it's pretty protective over time. So what does it all mean? So basically we found there's 4 possible different mental pathways leading from, with these different risk and protective factors to suicide ideation. There's both evidence for the stress exposure model with the life events, but probably the largest effect was with that stress generation path. Basically, the behavior of substance use at 18, leading to the experience of stress later on in negative life events, and that leading to ideation. It's pretty good what they found that social support is protective, as I might expect. That it goes on just even starting in early adolescence all the way to adulthood, that social support plays a major role in mitigating effects of stress. And we find that negative life events itself is a more proximate predictor of SI. So that was the most consistent predictor. So it's important to focus on positive coping with stress at different stages of development. So with a developmental model like this, we could identify different targets of interventions at different time points. With the associations with alcohol use at age 18, having some programs or interventions to target alcohol use at that time, so that we could try to reduce the negative consequences that we see in our model later on. We see the importance of social support throughout the lifespan. So promoting and maintaining social supports as early on as in adolescence can have major effects later on in adulthood. And generally with the negative life events being predictive of suicide ideation, ways to have positive coping with stress across the lifespan will be important. So some strengths is it's a longitudinal study. We got to see across developmental stages, across different, from adolescence to adulthood. It's a community sample rather than a clinical sample. And unlike some other studies, we both included both risk and protective factors to see how they interplay. All studies have limitations. Ours was, if you noted, there was a different time intervals from 18, 22, 4 years. Then it goes from 15 to 18 to 3 years, is 3 years. Then it's 4 years, and then 5 years. So a lot could happen in between those times. So future work should probably look at smaller time frames in terms of measurement to see what's actually going on. There was a change in measures over time, and that kind of contributes to also the last part of we were missing the adulthood social support measure. As I mentioned, the adult measure was added later on, and they were unable to add that social support measure, but also could point to, in really thinking about these type of developmental studies, consistent measurement over time. Thinking about where we're using measures that are validated both in youth and adults in order to keep the continuity, or having this in mind of like how we're going to deal with different constructs we want to measure, but then their developmental stages changes how we should measure it. And yeah, I want to thank my collaborators. The Leah Fellowship, where this is where I first did this for my leadership project, and then had this good feedback and presented this first time. The study participants, of course, and their families, and you all for listening. And yeah, any feedback would be great, because I'm presenting this at ABCT in November as well, so a third time. And now I'd like to introduce Dr. Nicole Groves.
All right, hi everybody. I am Nicole Groves. I'm going to be presenting a project today using some data from one of our outpatient groups in the Behavior and Attention Management Program, looking at differences in outcomes for white caregivers versus BIPOC caregivers. We've got some quantitative and qualitative data as well. Before I get started, I want to thank these people. So Jess Chong, who was a psychology resident this past year, she's one of the primary authors of this work, and she has been involved in every step. Erin Gonzalez, who is our faculty member, mentor, and then, of course, the whole BAM team for all the work they do in this program every day. For background information, we know that disruptive behavior is among the most common childhood problems that cause people to seek treatment. And we also know that parent behavior management training, or PBMT, is well studied, and it's the first-line psychosocial intervention for these sorts of problems. And we also know that most PBMT research and implementation focuses a lot on white caregivers and children and families. And that studies that do consider race or ethnicity typically find that BIPOC children have diminished response to treatment, and a lot of other research that focuses on specific cultural adaptation is kind of the main place where we see BIPOC folks considered in PBMT research, and that is wonderful when those cultural adaptations are available. Part of the struggle there is that it's challenging to have access to and find those specific adaptations, and so our goal here was to look at how these things are working in an already existing system of care. So we compared quantitative treatment outcomes and satisfaction with our group between white and BIPOC caregivers. And then we also examined some themes from qualitative data to understand perceived benefits and barriers of the intervention. For those of you who may not know, super parenting is one of our lowest tier interventions in the behavior and attention management program. It's a 9-week telehealth PBMT group. People meet for 60 minutes a week, and then they have a 30-minute individual post-group visit to review progress and talk about next steps in treatment. We have caregivers of up to 18 patients per group, and we usually have at least 2 leaders. Data that you're going to look at today are from our 5 to 8-year-old groups and 9 to 11-year-old groups. And then you'll also see breakout rooms referenced in some of the qualitative data. We use those smaller breakout rooms to do things like home practice review, goal setting, stuff like that. All right, so these data were collected as part of routine measurement-based care in BAM. So everyone had the option of filling it out, and we used patients who were enrolled in the calendar years of 2022 or 2023. We had a high number of patients enrolled during that time, but only about 25% of them had at least some pre and post-treatment data. So those 177 folks are our final sample here. Of those 177, the majority of those caregivers self-identified as white, and then we had 39 BIPOC caregivers. Unfortunately, to conserve power, we had to collapse across racial and ethnic minority groups, which is a massive limitation of this study. There weren't any pretreatment differences in child demographic characteristics or in child or caregiver functioning. White caregivers did attend significantly more sessions than BIPOC caregivers, which is consistent with the broader literature in terms of more barriers to care for BIPOC folks. And so all of the quantitative results that you'll see here control for session attendance. All right, so this is data on child ADHD and oppositional defiance symptoms using the disruptive behavior rating scale. Important things to note here in terms of pre to post improvements, only children of white caregivers were rated as experiencing significant decreases in inattention and hyperactive impulsive symptoms. Children of white and BIPOC caregivers had significant decreases in oppositional defiance symptoms, and the degree of difference was similar across groups. This is overall functional impairment for children, so it's looking at how impairing behaviors and symptoms are across domains like family life, school, and peer functioning. So this is the overall impairment here. What you can see is that both groups had significant reductions in impairment from pre to post treatment. The effect was greater for children of white caregivers. And then lastly, these data are from the Alabama Parenting Questionnaire, which has caregivers self-rate their own engagement in certain parenting behaviors. Only significant thing here is that white caregivers reported a significant decrease in their use of inconsistent discipline from pre to post. But as a disclaimer here, the range for these scores is 3 to 15, so you can see there's some clear ceiling effects on self-ratings of positive parenting and clear floor effects on self-ratings of poor supervision. So not a lot of wiggle room there to begin with. All right, and then in terms of quantitative satisfaction rating, so these questions we have folks answer on a Likert type scale. Overall satisfaction was high, and it didn't differ across groups. We do ask people about specific components of group and how satisfied they are with those things. And white caregivers were more likely to agree that they could follow along easily in group and that they would recommend the group to others. Okay, so then moving into some qualitative results, we have 5 free response questions that are included in our measurement-based care. And Jess and I derived themes and coded each of these questions. So at pre-treatment, we ask folks about what their goals are for group. You can see some themes here. Importantly, the overall proportion of white versus BIPOC caregivers that had excerpts fitting within a particular theme on each domain didn't differ except for one very specific point, which I'll point out later. But you can see here, the most common goal for group was to gain parenting tools or improve some aspect of their child's functioning or improve their relationship with their child. And then at post-treatment, we ask the rest of these questions. So here you can see things that folks identified as most helpful aspects of group. Far and away, the most helpful aspect for most folks are specific content or components of different PBMT skills. So you'll see here folks endorsing that special time, reward systems, ignoring behaviors, timeouts, things like that are very helpful. And then the next piece that people find very helpful is the discussion and support that they receive from other families in the group. We saw a lot of this idea of like not being alone and being able to get advice from other people. The next three questions talk about ways that we can improve. So we also asked folks to identify the least helpful parts of group. These are the four most common themes that emerged. There are a couple, and also the pacing of groups. So lots of folks felt like things moved really quickly, or there was a lot to cover in a little bit of time, which is accurate. And then we asked people about ways to improve. Again, here, I think one of the biggest themes, even if it doesn't quite fit in each theme box, some of the most feedback that we got was about timing and pacing, wanting to have more time and wanting to have more individualized time, either to speak in group or to speak with group leaders. And then another common piece of feedback that we got was that caregivers wanted more time to interact with each other, either virtually or in person. And then lastly, we asked people about ways that we can make the group more inclusive. These were the top themes. There are a couple of others that were infrequently endorsed. And this suggestion of increasing diversity in group is the only place where there was a significant difference in the proportion of white versus BIPOC caregivers that wrote something that fit in that theme. And all of the suggestions came from white caregivers. I do think if we look at the data overall, we have a lot more feedback about goals and the most helpful aspects of group and a lot less feedback about ways that we can improve. And I think especially when we think about free response questions and what people feel driven to put in those things, it might be more challenging for BIPOC folks to kind of write things like this. All right, and then in terms of limitations and implications, as expected, these caregivers participated well and they saw improvements related to group, and there are still lots of gaps and things to fill in here. So one crucial limitation is that this sample only represents about 25% of the families who were enrolled in super parenting during that time. The benefit of this, though, is that this probably represents our most engaged families in terms of folks who returned pre and post data. And so if we were getting this kind of critical feedback even from our most engaged families, I think it is relevant to all of our families. The other massive limitation is that we had to group all of our BIPOC caregivers into one group when we know it's not a monolith, and there are lots of differences and things that we need to consider there. In terms of implications, I think there are certainly implications for our super parenting groups, but I think for outpatient psychiatry groups as a whole, lots of practical ways that we can improve. So doing things like offering more time, considering pacing of groups, reducing some of those logistic barriers and things like that. And then there are a lot of things that people liked about the group, and so we can harness those strengths and keep working towards them. That is it for me. And up next is Dr. Gabby Sepulveda.
I'm Dr. Gabby Sepulveda, and today I wanted to give you all a very quick view of some of the work that I've been doing with serving autistic youth within the juvenile justice system, and more specifically, serving autistic youth who have been incarcerated. So very quickly, the majority of my work is actually done at Echo Glen's Children's Center. It is a medium to maximum security facility, and it actually provides treatment services and houses both boys and girls. One of the most common misconceptions that I often get when I'm talking about this population is this belief that autistic youth aren't really ending up incarcerated. This is a very rare kind of thing. But reality is that youth with intellectual and developmental disabilities are actually overrepresented within the system. It gets a little hard to tell whether autism itself is overrepresented or not, mainly due to lack of research, but we do know that autistic youth are being incarcerated and their needs are often being overlooked. Now, with incarcerated autistic youth, we tend to see these patterns. So they're either here for like a set of common offenses, they're likely coming in undiagnosed or misdiagnosed, and they have a very, very difficult time adjusting to incarceration. So in order to give you all a better idea of some of the work that I'm doing, I wanted to introduce you all to Malik. Obviously, not a real name, but this is a youth that I worked with while I'm at Echo Glen. So Malik was introduced to me as a 15-year-old cisgender black male. He was here for assault in the second degree, and he had a long list of diagnoses. Really, the main reasons that he was brought to me was he was very physically and verbally aggressive towards staff and residents and did not follow directions or instructions. Pretty much he was brought to me because staff was having a really difficult time working with him. Now, Malik had a very, very long and sad history. This is a very, very condensed version, several CPS involvements, past sexual and physical abuse. He had lost a lot of people close to him. He had substance use history. This was not the first time being involved in the justice system. He had several inpatient hospitalizations, and he was a gang member. So when I started working with Malik, what I found was that the majority of his symptoms, if not all of his symptoms, could actually be explained by a combination of PTSD, ADHD, and what at that time was undiagnosed autism. Now, at this point, I knew I was going to have to assess him for autism, but that is like a whole other story because before we could even get to that, we needed to help Malik adjust to Echo Glen. He was having a really, really hard time. And he was actually putting himself in positions where like his physical safety was actually in danger. So this is where I started working on creating a treatment plan, creating behavioral plans, and really this is where a lot of those unique aspects of this job came up, not only as I created the plan, but as I tried to implement it. For example, the environment. Remember, Malik is incarcerated, and places like Echo Glen, they try their best to create some sort of routine, some sort of schedule, but the reality is that they're very inconsistent, unpredictable, and generally unsafe places. Now, for an autistic youth like Malik, this was extremely distressing. He really struggled with the inconsistency and unpredictability. And for me as a therapist, I had to come to the realization that there was very little I could do to actually change that environment, and that a lot of the strategies that I would have typically used for other autistic youth were not going to be super helpful in this case. For example, Malik really appreciated a visual schedule. However, that only worked if the schedule could actually be followed. Most of the time, what we found that at Echo Glen, the schedule was not being followed, and this was actually causing more distress for Malik. Additionally, things like gangs make the place very unsafe. Even things like trying to find a consistent time and date for us to like meet weekly for therapy was really hard. Several times I would call for Malik to be brought to me, and then it would take almost an hour to get him to me. Other times he would be on his way to see me, and all of a sudden somebody would find several shanks in someone's room, and the whole campus was shut down. So there was just a lot of struggles. Other things that I really had to consider as I was trying to work with Malik were the rules. Now, Echo Glen is a juvenile rehabilitation place, and that means that it comes with a lot of rules. For example, one of the things that we found for Malik was that he was better able to regulate if he had the right sensory accommodations and if he was able to take a break. Now, both of those things should have been easy, but they were actually incredibly difficult at Echo Glen. First of all, he really benefited from noise-canceling headphones, and that was something that Echo Glen was not willing to approve. That was not something I could get access for him. And then other things like taking a break, he needed permission to take a break. At one point, Malik, trying to use his emotion regulation skills, asked for a break, was denied that break, still being overwhelmed, decided to step out of the room. Now, at that point, Malik was able to avoid the fight, but what he was also able to do was put himself what considered AWOL, which means that he was now being considered as having attempted to run away from Echo Glen. And that meant that for the next couple of weeks, everywhere he went, including therapy, he had to have handcuffs in his arms and his legs, and that he was now facing possible new charges. Additionally, at Echo Glen, there's a lot of unique social dynamics that come with a lot of unspoken rules. Now remember, Malik was part of a gang, and gangs have very unique social dynamics, but also come with a lot of unspoken rules. And for me as a therapist, I was finding myself in this position where I was having to learn the social dynamics of the gangs and try to help him manage them. At one point, a member of Malik's gang entered his room and took something of his. And Malik, trying to avoid an actual physical altercation, decided to go tell the staff. Now, for the staff, this was great. This is what they wanted. For the gang, this was bad news, because what he had just done was broken several unspoken rules. And this created this very, very dangerous situation, actually, where Malik was not only having to watch out for opposing gang members, but he was also having to watch out for members of his own gang who were now seeing him as a snitch, as a traitor. And for me as a therapist, I found myself in this really weird position where I was actually trying to get him to go back on the good graces of his gang, even though ideally I would not have wanted him to be gang involved, but his physical safety was actually in danger, and there was a lot of situations where we were actually very scared for his safety. Now, other things that I was finding myself kind of working around was the people that were around Malik. Now, at Echo Glen, Malik is surrounded by security guards, opposing gang members, and members of his own gang. And all these people often served as trauma reminders. So pretty much this meant that Malik was surrounded by trauma reminders 24/7. At one point, Malik was actually expected to be in the same room as an opposing gang member who was partially responsible for the death of one of his friends, and he was expected to just stay calm and continue doing his things. Additionally, in Echo Glen, we see a lot of limited support and high employee turnover. So Malik already had a really hard time connecting to people, and people had a really hard time understanding the way that he communicated and really understanding how to help him. And what we found was that anytime we would find someone that he was starting to feel comfortable with, that was starting to understand him, that person would leave. And Malik was finding himself having to reconnect over and over and over. And this was something that was hard for him. For me as a therapist, it meant having to go over my behavioral plan several times, almost weekly, and understanding that most of the time that behavioral plan was not even being followed. And it really made me question at points like whether my expectations that I was setting on Malik were fair, because he was not getting the support that he needed. Additionally, with limited support, and in Malik's case, and sadly in the case of a lot of the youth at Echo Glen, Malik's family was not in the picture. They had decided that they no longer wanted to be involved with him and had told him that even once he was released, he could not go back home. This created a very unique situation where I was having to step in and staff was having to step in parts of my treatment plans where I would have typically relied more on family to provide some sort of support. Now, to kind of finish this off and give you an idea, I wanted to share a quote from Malik. At one point, Malik was in therapy with me, and as he's crying, he tells me, I would rather spend the rest of my life in CI than have to deal with this. Now, CI is central isolation, and pretty much this is solitary. Malik was struggling so much that he told me that he would rather spend the rest of his life in solitary than have to deal with what he was dealing with. And I think this quote is very helpful, not just to give you an idea of Malik's experience, but also give you an idea of the experience of most autistic youth who end up incarcerated, and really to give you an idea of what a unique and complex population this is, why I'm so interested in this population, why there still needs to be so much more training and research and just work with this population. And I included some references, but there's very limited stuff, obviously. Thank you. Now, I'm introducing you to Dr. Kelsey Straub.
Good morning. I am Dr. Kelsey Straub, and I will be presenting on reducing the duration of untreated psychosis in Washington State and the Central Assessment of Psychosis Service. So the duration of untreated psychosis is defined as the time between the onset of psychosis symptoms and the initiation of treatment. And DUP is known to be a prognosticator of the psychosis trajectory. So reducing the duration of untreated psychosis through early intervention not only improves short-term outcomes, but there's evidence that these outcomes are sustained up to 20 years later in improved treatment response, increased likelihood of remission, less severe overall psychopathology, improved social functioning, and improved overall functioning. So early detection and intervention for psychosis has been identified as an important public health goal. The World Health Organization back in 2005 set a target to try to keep average DUP under 3 months. And there have been pretty large investments made by the US Department of Health and Human Services, as well as a lot of state governments. But despite these investments, DUP in the US has remained high, with most estimates around 18 months. And that is despite the increased availability of a lot of early psychosis intervention services. There still seems to be a large unmet need. We also know that DUP is linked to public health disparities. We see longer duration of untreated psychosis among racial and ethnic minorities, people living in geographically rural locations, and people with low socioeconomic status. So zooming in here to Washington State, we have the New Journeys Network. So New Journeys is a network of coordinated specialty care teams providing evidence-based treatment for individuals experiencing a first episode of psychosis. And here in Washington State, we have 14 New Journeys established teams and 8 more startup sites. So like we have in a lot of places of the country, we really have seen a proliferation of the availability of these early psychosis intervention services over the past couple of decades. However, pathway to treatment at locations like New Journeys can be long and circuitous. It's often not easy to get straight into treatment. We describe our current kind of standard care pathway as all crisis and no catch. So even it can take someone a while to realize that they need help when they're experiencing symptoms like this, to recognize their problem as psychiatric and to feel comfortable seeking help. Even once they do, they typically don't know where to seek help. They don't know about New Journeys, so they might ask their primary care provider, they might talk to a counselor at a community mental health center, a school counselor. If their symptoms are more severe, they're likely interacting with crisis or emergency services or even with law enforcement. And so all of these experiences not only represent time in which psychosis is going untreated and we're therefore missing that kind of critical early window for intervention, but also these experiences can be aversive and even traumatic, which exacerbates the symptoms that these people are experiencing and makes them less likely to feel comfortable and safe seeking help at the medical system in the future. And again, we see this exacerbated for our most vulnerable populations, like people of color, especially Black individuals, who often have higher rates of skepticism, lower trust among medical organizations where they've typically faced discrimination. We can see this in the New Journeys data as well. So the New Journeys 2023 admissions data, so this doesn't even include all of the people who never got into treatment. Just the people who did receive treatment at New Journeys in 2023 still had an average 154 days of untreated psychosis and 1.3 psychiatric hospitalizations before starting treatment. So we can see there's still a lot of opportunities for us to be catching these people much earlier in that care pathway. So we need to take a more nuanced look at DUP and the factors sustaining it to understand how to decrease it. Generally, we can group these factors into delays associated with help seeking. This is often driven by stigma regarding psychosis or regarding seeking help for mental health services in general, and an inability to recognize the problems of psychosis as psychiatric in nature. Even once people decide to seek help, they often have delays in referral to appropriate services. There's often a lack of awareness of the proper resources by the healthcare providers where they're seeking help, and this is also where they can accrue those aversive experiences. Finally, even when they are referred to the appropriate services, they might further receive delays in administrative procedures such as wait list, or things like misdiagnosis and referral to inappropriate services can make that wait even much longer. So because there are so many different components maintaining DUP, we really need a multi-component strategy in order to reduce DUP. So we need a strategy for early identification of psychosis and psychosis risk, rapid referral to evidence-based coordinated specialty care teams, and effective engagement with those CSC teams. And that is what we are trying to do with the Central Assessment of Psychosis Service, or CAPS. So why is availability of these early intervention services not translating to accessibility of those services for the people who need them? Families describe a lot of challenges finding care. They report being bounced around through different referrals or referrals getting dropped. Similarly, providers talk about a black hole. They don't know where to send people when they're experiencing these types of symptoms. The New Journeys teams in our different counties have a lot of variability in their wait times and whether or not they're fully staffed. And understaffed teams often don't have the capacity to conduct outreach within their communities or to conduct the specialized assessments. One way that we are trying to subvert that is with the Central Assessment of Psychosis Service, centralizing the assessment process and creating one front door through the state through which anyone can get psychodiagnostic assessment for psychosis. This would eliminate that kind of maze of healthcare system that a lot of our families describe and would relieve a lot of the burden on these New Journey teams that often have staffing shortages in their trainers, in the people who are supposed to be conducting this outreach and doing the assessments. So rather than trying to have someone on each of the 25 New Journeys teams who is trained to do these specialized assessments, we can centralize that and leverage university clinicians. So the CAPS team at UW can include these navigators, these diagnosticians, credentialed and standardized assessments, also consultations with neurology, with autism clinic for ruling out different comorbid conditions or medical conditions, with clinical support staff, and telehealth consults with UW Medicine. So this employs the task sharing model to try to more efficiently allocate resources and reduce the burden on those New Journeys teams so that they're not taking a lot of time and energy up front, assessing a lot of people who are not going to be eligible for their services. So rather than training a lot of people to do these assessments, we can provide more extensive specialized training to a fewer number of people. Additionally, CAPS uses telehealth, and that allows us to overcome the geographic barriers that have traditionally disadvantaged more rural and less affluent communities. There's a lot of good evidence showing that telehealth is accessible and acceptable to a lot of these people. 96% of Washingtonians have internet access, and much of our population has endorsed that they would feel comfortable receiving care and receiving more information over telehealth, and it's becoming a very commonplace method for healthcare. Finally, CAPS will include an outreach campaign, a psychosis awareness campaign designed to increase awareness of psychosis, recognizing the symptoms, recognizing them as psychiatric, and knowing where to seek help for the symptoms. So decreasing stigma around psychosis and help seeking, as well as increasing knowledge of CAPS and of New Journeys. And this would include not only an outreach campaign to the general community, but also more specialized outreach to providers in that standard care pathway. And working with community partners to develop targeted, culturally resonant information materials for diverse communities with diverse communities, knowing that we need to do more outreach to build trust and spread awareness within these minoritized communities that show even longer DUP. Our ideal for an enhanced care pathway would be that we would have a decreased delay up front in people's time before they want to seek care. And then rather than going through the care as usual pathway where you can have all these aversive experiences, that instead people would be routed to CAPS for an assessment, and if appropriate, would then get routed directly for treatment at New Journeys, ideally reducing that reducing the duration of untreated psychosis and minimizing or eliminating those aversive experiences such as involuntary hospitalizations and encounters with law enforcement during mental health crisis. Finally, in my last moments here, I would like to give a shout out to the Early Psychosis Clinic here at Children's. We are doing diagnostic evaluations for youth ages 13 to 21, experiencing symptoms concerning for psychosis such as hallucinations, delusions, unexplained changes in thinking or behavior. We also have currently very limited capacity for ongoing individual psychotherapy and consultation regarding medication management, but we're greatly expanding our services and treatment capacity within the next couple of months. If you do have a patient you think could be appropriate, please either place an EPIC ambulatory psych referral to the Early Psychosis Clinic. You can EPIC message me or email me at kelsey.straub@Seattle Children's. And I believe these slides should be distributed. So please don't hesitate to reach out with any questions about Central Assessment of Psychosis Service or the Children's Early Psychosis Clinic.
So I would actually like to invite you all up here for some questions. We only have 5 minutes, so it's not a lot. Don't worry. But I would love for you guys to be in front of the microphone, and then maybe we can get any questions from the chat or from the room for all of you together, especially because some of your work has some really exciting overlaps as well. And it looks like Erin already has a question.
So this is for Dr. Gepti. So I was noticing on your slide of the waves that alcohol use at, I think it was the age 15 time point, didn't seem to correlate to any other outcomes, including later alcohol use, which I thought was quite surprising. So I was wondering about your hypothesis around that outcome. I'm wondering if maybe it was lack of power due to the amount of people that were using alcohol at that age group. And then I'd be really curious to understand the outcomes of those that were using alcohol at that age time. So what are your thoughts?
Yeah, I would have to look back at the frequencies. I think it was pretty low in terms of the use at that time point. And yeah, in terms of kind of their outcomes from the youth who do, I could check on that. Yeah, that's something that I have to look back at the data to see at that, because it was interesting. Because yeah, that was like the only time point other than suicide ideation time points, but that was the only time point that wasn't prospectively associated with anything. So I would have to look back at the frequencies there. I assume that's based on the low. Probably most likely the low amount of usage at that age, I would hope. But that's my thoughts on that, yeah.
In terms of interpreting the effect size for suicidal ideation, I want to know more about that variable as it was coded. Is that frequency in attempts of suicidal ideation, how serious the suicidality is reflected in that ideation? And if it's a normally distributed variable, because I think that potentially not normally distributed, and there would be implications for interpreting a G or H type of effect size.
Yes, great questions. So with the suicidal ideation measure, so it was dichotomized based on a cutoff of whether or not it was present or not, rather than the continuous. I did try it with both ways with the continuous data, but it didn't fit the model. In terms of the, if I remember correctly, I double check. It's somewhat zero inflated. I'm not sure. I got to double check on that. It's a good question. But yeah, those, there are different implications with it being dichotomous, since now it's predicting to, I guess it's kind of like logistics in a way. Yeah, I'll double check on that, but yes.
So maybe if you're going to present that, you asked if there were suggestions,
Mhm.
maybe think about presenting that as odds ratio
Ah.
rather than effect size.
Okay, I gotta figure it out in R, but yes. Yeah, I gotta look. But no, it's a great point. Especially, we're trying to write this up for publication, so that'd be good. That's a good suggestion. Thank you. Yeah.
I was wondering what scope of work makes these providers feel most effective? Are there any elements that you think leads to greater effectiveness or perceived competence by these providers? And how can we really best train and leverage the supports that they can provide?
That's a really good question. I don't have a solid answer. I think that we're in a position where we are responding to an increase in need, and we still have a lot that we don't know about, best ways of training or best roles for paraprofessionals. But one thing that's been on my mind is if I recall from my grad school education, that a consistent finding with therapy is this like therapeutic alliance that we see associated with better outcomes and validation. And I think that paraprofessionals can support clinical interventions and can support medical interventions in a sense that they can do this sort of task sharing where there's some part of a clinical intervention that they can either deliver, take over after a provider does whatever is needed. But I think that the ongoing thing that we can benefit from is that therapeutic alliance and that validation that paraprofessionals can provide families after they see a provider in these short bursts, which is what healthcare facilities have the capacity for right now. But there's so much to learn and so much to know. And I know that there are some of the community health workers on the Zoom call right now. And I'm really excited to continue learning from you all about like what that role is, what benefits you see. So that's my 2 cents.
Thank you so much, Dr. Bolden. I am so sorry, but we are a little over time, so I am going to have to end it there. But please reach out to this incredible group of individuals that will be hopefully sticking around and doing some of this work going forward. So thank you so much for attending, and have a great rest of your Friday, everyone.